This talk is about the use of bridge plate distraction osteosynthesis to manage complex fracture dislocation of the proximal interphalangeal joint. Now, periarticular fractures with severe joint and metaphyseal comminution pose a real reconstructive challenge. An anatomical reduction, as is normal in articular fractures, is not always possible. Indeed, excessive dissection of the metaphyseal and joint fragments can result in soft tissue stripping and avascular necrosis. Opening the comminuted metaphyseal bone results in disruption of the fracture hematoma, which may favour callus healing, and soft tissue dissection can impair vascularity. So traditionally these complex fractures would be managed in a number of ways. External fixation, which spans the fragmented joint. External fixation with limited attempts at internal fixation, fixing key fragments. Even the plaster of Paris bag of bones technique has been used around the elbow. Primary arthroplasty may be accomplished. So again, in the elbow, the Coombe-Moray hinged elbow replacements may be used with good effect in elderly patients with comminuted fractures. Secondary arthroplasty can be undertaken, secondary arthrodesis, but I'm going to talk about bridge plate distraction osteosynthesis. Now, this isn't a new technique. In fact, bridge plating has been applied to comminuted fractures around the wrist for many years, and here the aims are relative congruency of the joint, restoration of length and alignment, distraction of the joint fragments to offload them and prevent chondrolysis, minimal soft tissue dissection, staying well away from the damaged joint fragments, and a temporary bridging of the joint until callus healing is established, and then plate removal with early range of motion. So the first case I'm going to present is an open fracture dislocation of the PIP joint from a crush injury to the index finger in machinery. The finger was of doubtful vascularity with poor capillary return. There was disruption of the neurovascular bundle, and it was felt that attempts at anatomical reduction would not result in a stable fixation, and it was hoped that we could avoid a primary arthrodesis of the joint. A temporary 1.3mm bridge plate was applied through the volar wound underneath the flexor tendon with minimal dissection, and this was to restore relative length and alignment. The joint fragments were offloaded, there was no soft tissue dissection, and effectively this acted as a static internal fixator, and the plate was removed at 6 weeks with limited tenolysis of the flexor tendons. Excellent anatomical reduction of the joint was achieved, stable union, and a good range of motion from 5 degrees to 80 degrees. This was pain-free. Case 2 is a comminuted P2 base fracture with central slip fracture fragment. The volar fragment is quite large, plus there's metaphyseal comminution. Here again the soft tissues dictated management, and it was felt that external fixation would be appropriate. However, in this case, a 1.3 bridge plate was applied dorsally to buttress the central slip fragment with a lag screw to effect reduction of the volar fragment and a spanning distraction applied. Again, the fracture went on to heal well, and range of motion at final follow-up was 30 to 80 degrees, which was pain-free. Thank you.